Hi, I'm Dr. Thaïs Aliabadi. For over 25 years, as an OBGYN, I've helped countless women navigate the challenges of PCOS. I created OV to bring you a scientifically backed solution that supports the symptoms of PCOS with powerful ingredients. OV supports hormone balance, body composition, metabolic support, and beauty from within, giving you a comprehensive approach to supporting your health. It's more than just a supplement. It's a product born from decades of experience and a deep commitment to women's health. Visit OV.com to learn more and start your journey to better health today. That's OVII.com.
Welcome to this amazing episode where we're diving into a condition that affects millions of women worldwide, polycystic ovarian syndrome, or PCOS. We are here today to break the silence around PCOS, a condition that affects 15% of women, yet goes undiagnosed in up to 75% of cases, despite being one of the leading causes of infertility in women of reproductive age. It remains overlooked, misunderstood, and too often dismissed. That's why we're calling PCOS a silent epidemic, because it's a serious health issue hiding in plain sight. It's time, guys, to bring this conversation to the forefront of women's health where it belongs.
I see it every day in my office. Women coming in desperate for answers, struggling with symptoms of PCOS. They're exhausted, they're confused, and many of them feel like they're losing their mind because no one is listening. They're told to just lose weight or go on a diet as if that's a cure. It's really infuriating. I call PCOS a silent epidemic because it is. It is still one of the most underdiagnosed, under-researched, and undertreated conditions in women's health. That has to change. Today, I'm here to tell you we see you, we hear you, and you're definitely not alone.
So let's dive in a little deeper and try to demystify PCOS. Break down the signs and symptoms you should be looking for, how to manage your symptoms, and most of all, arm you with the knowledge and tools you need to become your health advocate. So I'm really happy we're doing this because we talk about PCOS a lot, but we haven't really done an episode where we just break it all down. So let's go to the basics. What is PCOS?
So PCOS, or polycystic ovary syndrome, is a condition that affects women mostly in their reproductive age. Depending on which country, which ethnicity, it can range from 10% to 20% of women struggle with this condition. We used to think it was only a hormonal imbalance and a reproductive issue, but now we know that it's multifactorial and there's not a single cause for PCOS. So we can't really test for one thing and diagnose someone with polycystic ovarian syndrome.
So kind of simplify it for me.
So to simplify it, PCOS is multifactorial. You have to look at your genetics. If you have it in your family, you're more likely to have it. You have to look at your gut microbiome. If you're bloated, if you have any imbalance of the bacteria in your gut, it can make you more insulin resistant and cause other issues with the symptoms of PCOS. It is definitely a metabolic problem. PCOS patients have insulin resistance, so we need to talk about how to make patients more insulin sensitive and less resistant to balance their hormones. It's a hormonal imbalance. They have higher testosterone, higher levels of LH and lower levels of FSH.
What are LH and FSH?
These are hormones that are secreted from our brain to regulate the follicles in our ovaries. And when there's a disruption in this secretion, then we get irregular cycles and irregular ovulation and therefore issues with pregnancy, for example. And the last thing I want to cover is the inflammation. This chronic inflammation is very important because sometimes that low-grade chronic inflammation can stimulate the ovaries to secrete more testosterone. So it's a multifactorial. You can't just treat the inflammation and, expect the PCOS to go away. You have to look at every single aspect and try to optimize the treatment. That's why it's so complicated to treat these patients.
You've seen thousands and thousands and thousands
That's
of
all
women
I see.
with women with PCOS. So can you kind of tell me, a girl comes in, and what are the signs that she has PCOS?
Very good question. So let's talk about how we diagnose polycystic ovarian syndrome. The easiest way to do it is look for 2 out of 3 criteria. Number 1 is history of irregular cycles. Number 2 is PCOS looking ovaries on ultrasound. To this day, even doctors think polycystic ovary syndrome is cysts on the ovaries. It's not. It's a specific finding on ultrasound. We call it string of pearls. There are a lot of follicles on ultrasound. You have to be able to recognize that. So you don't need to have a cyst. It's a bad name for it, but it's a lot of follicles in the ovary.
Can you have a cyst?
You can, but it's
okay.
It's when we say PCOS looking ovaries on ultrasound, we're not looking for a big giant cyst.
Okay.
And the third criteria is symptoms of high androgens. What are those? It could be facial hair, body hair being the most common, acne on the face, in the body, or hair thinning. Or you can also have high testosterone in the blood. But it's important to know that you do not need to have a high testosterone in the blood to get the diagnosis. To this day, doctors will tell their patients that, oh, your testosterone's normal, so you don't have PCOS. We know now that's not true. So if you meet 2 out of the 3 criteria, irregular period, PCOS looking ovaries on ultrasound, or elevated testosterone symptoms, we rule you in for PCOS. Now, a lot of women don't have access to ultrasound. They haven't had an ultrasound, or if they've done an ultrasound with their gynecologist who dismissed their symptoms and dismissed the findings on ultrasound. So in that case now, which I've been doing this for years, but now it's become more of one of the criteria. Instead of PCOS looking ovaries on ultrasound, we can use a high AMH level.
What is an AMH? Okay, good.
Yeah.
Good. I need to know.
AMH, anti-Müllerian hormone, is a hormone that gets released from the follicles. The more follicles we have, the higher the levels of AMH. PCOS patients tend to have a lot of follicles, and because of that, their AMH level tends to run high. So for patients who cannot have access to an ultrasound, the second criteria in adults could be an elevated AMH, or an egg count, we call it,
and
which is
a
blood
do you do
test.
that?
It's a simple blood test. You can ask your doctor. The average range is anywhere from, let's say, 1 to 5, but sometimes PCOS patients are in 16, 14, 10, so they're very elevated. And that's why I always tell you, if you have a 40-year-old whose egg count is off the chart, that's PCOS.
Yeah.
Sometimes patients come to me and they're like, well, my doctor said I have so many eggs.
Right.
Well, you're not supposed to have so many eggs if you're 40 years old. That's a sign of PCOS. I want to make sure we understand that for teenagers, we don't use the AMH criteria because they're younger, their AMH could be higher. For teenagers, they need to have the irregular period and the high testosterone symptoms to get the diagnosis.
But we've had so many women on this podcast, and one thing that a lot of them have said is the moment they got their period, or right after that, all of a sudden they gained weight, they couldn't lose it.
Yeah.
And so that's not one of the criteria.
Weight gain is not one of the criteria for diagnosis, but that's a very good point. Polycystic ovary syndrome is a group of symptoms that are all related. So it's a combination of these symptoms.
Right.
You do not need to have all of them to get the diagnosis. But just to list them one more time: irregular period, high testosterone symptoms, weight gain, mood changes, anxiety, depression, family history of insulin resistance, diabetes, overweight family members, history of an eating disorder, and of course the last one, PCOS is one of the top causes of infertility. These patients have tons of eggs. They go to the doctor, they get tested, and they get reassured by their doctor that they have all the time in the world because of the number of the follicles. But now we know it's not true because the quality of the eggs actually decline pretty fast after 30. So that's when egg freezing becomes a very important topic.
And you've said before that a lot of women with PCOS have endometriosis. And so that's the double whammy for the fertility, because
Correct.
you have a ton of eggs and then the endometriosis
Destroys
them.
So PCOS patients have higher number of follicles, but the quality declines as they age. Endometriosis, which affects 40% of PCOS patients, in my opinion, from my experience, Endometriosis affects the egg count and quality by lowering both. Because we don't know what the number of egg count is as a baseline in women, we don't know how much their endometriosis or how aggressive their endometriosis is, and we don't know how out of control their PCOS is, you cannot assume that someone has a normal egg count. That's why it's so important to check the levels. The blood test, as we talked about, is AMH. It's very simple. You get the results within a few days. I think every single girl, even at a young age, needs to know her egg count.
What age?
I would say if you have no symptoms of irregular period or painful periods, you can start at 18. But if I have a patient at 14 who has, really bad painful periods, and I diagnose them with endometriosis, I've had 14-year-olds with an egg count of a 40-year-old. Oh. So it's fine, because if you diagnose it in time,
right,
then as early as even 16, you can freeze their eggs with parental consent. Yeah. If the parents don't consent to it, then at 18, you can talk about egg freezing to these patients. But most parents want their children to have the option of fertility. I have a few patients in my practice right now. I suppress their endometriosis at a very young age. I follow their egg count every 6 months to every year. And between 16 to 18, I have them freeze their eggs.
You see so many girls and women that all of a sudden, they have PCOS, they get their period, and then they all of a sudden can't lose weight. What causes that?
So at its core is insulin resistance. Mm-hmm. But again, other factors can affect it. Your gut microbiome imbalance can affect your insulin resistance. Inflammation can affect it. Your genetics can affect it. So there are multiple factors. But at its core, that weight gain comes from insulin resistance. Okay. Normally, when we eat carbohydrates, our body breaks it down into glucose. Glucose stimulates our pancreas to release a hormone called insulin. In simple terms, the job of insulin is to open up the receptors on the surface of our cells so the cells can grab the sugar out of the blood, put it in the cell, and turn it into energy. This is what's supposed to happen. Mm-hmm. But PCOS patients have insulin resistance. And what that means is for these patients, when they eat carbohydrates and their body breaks it down into glucose, the sugar stimulates their insulin, but their cells are not responding to this insulin. So the receptors are not opening to grab the sugar and put it in the cell and turn it into energy. Instead, the sugar stays in the blood, pushes their insulin to go up. And as the insulin goes up, the symptoms of PCOS shows up. Insulin is a fat storage hormone. It stimulates your body to clear that sugar from the blood and stored as fat. So these are patients who have one slice of pizza and they gain weight, and their skinny friend eats the whole pizza and shows up the next day in their skinny jeans. So that's one, weight gain. Number two, high levels of insulin stimulates our ovaries to secrete more of the androgens, the testosterone. And it is the testosterone that causes us to not ovulate, to have irregular periods, to have acne, hair loss, facial hair, body hair. So what we eat and how we process that sugar can give us irregular period and acne. What happens to these patients? They go to the dermatologist will treat their acne. Then they go to their primary care. The primary care is addressing their weight gain. Then they have a trainer. Then they go to another doctor for their hair loss. Do you know what I'm saying? So then they go to the GYN and they get birth control for their irregular period. It's important to know that all of these symptoms are under one umbrella of PCOS.
Okay, so you have somebody come in, they have all the symptoms of PCOS, you diagnose them with PCOS. What do you do? How do you deal with the sense that there's no cure for PCOS, but what is a treatment?
So first of all, you're right, there's no cure. But when we talk about PCOS, we deal with the symptoms. Different patients show up with different symptoms, so it can be very confusing for healthcare providers and for the patients themselves. If patients have irregular periods as their only symptom, then a lot of times you see doctors will prescribe birth control pills. Generally speaking, PCOS patients tend to have mood disorder, they're anxious, they're depressed, and sometimes they're very sensitive when you give them systemic hormones. So there are different ways of fixing that irregular period for patients who don't want to take birth control, or they just don't feel good, or they get moody or depressed on birth control. So it goes back to that insulin resistance, right, as the first line of therapy. If I think they're insulin resistance, lowering their insulin will lower the release of testosterone from their ovaries. So diet is very important. I explain to them what insulin resistance is, and I talk to them about following a low carbohydrate diet. That's number one. Number two is exercise. As we exercise, we open up these receptors on the surface of our cells that pull the sugar in and turn it into energy. So it reverses our insulin resistance. Walking after each meal, I usually tell my patients walk 10 to 15 minutes after each meal and clear that sugar out of your blood. The problem is for PCOS patients, diet and exercise is not enough, and that's why they get so frustrated.
We've heard that again and again. They're like, I can't exercise more. I can't eat less.
There you go. So the other way to address it, I'm sure you've heard of metformin. We've talked about it. We've used it for many, many years for PCOS patients. Metformin works at a cellular level, and it helps patients become more insulin sensitive, clearing that sugar out of the blood. By doing that, we lower their insulin. By lowering their insulin, we can balance their weight. But by lowering their insulin, we also lower their androgens that are secreted from the ovaries. And then their symptoms improve. Their periods become more regular. Their acne, hair loss, facial hair, body hair resolves. Then we talk about supplements, inositol being one of them. Supplements that work at a cellular level and help patients balance their hormones and become more insulin sensitive. So all of the metformin and the supplements, diet and exercise are helping with lowering the insulin. But we also have at the bottom the symptoms of PCOS, just the ovaries secreting those androgens. How do we fix that? Generally speaking, we prescribe birth control pills. PCOS patients have, this might be a little bit more technical, but it's important to know, a lower level of sex hormone binding globulin. These are proteins in the blood that basically act as a magnet and grab the free testosterone in the blood. So what happens when the levels of the sex hormone binding globulin is low, your free testosterone levels are higher in your blood and can cause symptoms. Birth control pills stimulate this sex hormone binding globulin, so they start grabbing the free testosterone and our symptoms resolve. That's why a lot of doctors prescribe birth control pills for symptoms of acne, irregular periods to fix these symptoms.
But if you can't take a birth control, like you said, what do you do?
Then we use spironolactone or aldactone, which is also an anti-testosterone. It lowers testosterone levels and helps with the symptoms of PCOS. So the combination of diet, exercise, metformin, supplements to balance our hormones, birth control pills. Then we have anti-testosterone creams that you can apply for facial hair and body hair. And near and dear to my heart are GLP-1s, medications like Ozempic, Wegovy, or tirzepatides like Mounjaro and Zepbound, which I started using these medications in 2014 for my PCOS patients. And now we have studies that are just being published how it helps PCOS. So for patients who struggle with weight, their BMI is 25 or more, you can absolutely use these GLP-1s, which has been a game changer for PCOS patients.
So what is the difference in what metformin does and what GLP-1s do?
Completely different. So the GLP-1s regulate your insulin, right? The metformin makes your body respond to that insulin.
Okay.
To make it very simple.
Okay, great. So is that's how you treat it?
That's how I treat it. However, we have new studies that also associate gut microbiome imbalances to insulin resistance. And we know insulin resistance causes the symptoms of PCOS to worsen. So it's very important when you take a history from a PCOS patient to also ask about any bloating, any pain, any GI symptoms, because now there's a direct link between that gut dysbiosis and insulin resistance. So that's another factor.
So how do you treat that?
Usually you have to, if they have small intestinal bacterial overgrowth, you can do a test. I refer to a GI specialist, but it's something that needs to be addressed. PCOS patients have this chronic inflammation, and that needs to be addressed because that chronic inflammation sometimes stimulates the ovaries to secrete more testosterone.
So basically when I met you, we were talking about the two things that you wanted to change in the world. And one of them was every woman needs to know her lifetime risk of breast cancer. And the other one was to get PCOS on the lips and ears and hearts of everyone.
And endometriosis.
And
three things.
Yeah, and endometriosis. You want a sign that says painful periods are not normal. So what was so interesting about that, you started started telling me about PCOS, and I asked you, how do you treat PCOS? And you said there are actually supplements that you can use. These will deal with the symptoms of PCOS and help lower insulin, help with the testosterone. So we found the most incredible scientists, actually two, to work with you. And that's how we created OV. And it was this was thoughtful. We did research. It's scientific. It's evidence-based. It's science-backed. So how do you use OV? Because I know instead of any other supplement, you give it to every single patient.
I do. I love supplements, and I've prescribed them for many, many years. The problem is, in the past, before OV, my dream was always to make a supplement where you take one packet and it addresses most of the symptoms of PCOS, from hormone balance to our metabolism.
And inflammation,
all of it. But again, PCOS is not a condition where you can just treat with one supplement or one prescription. It's a holistic approach to the treatment for every patient. Generally speaking, I recommend it to every single patient of mine with PCOS, especially the ones who I start on GLP-1s, because these medications tend to have side effects of nausea or diarrhea and constipation. So I usually combine it to make the medication work better. And eventually in 3 to 4 months, then I add the metformin. So I have a lot of my patients who do the shots, do the OV supplement, do the metformin. Some of them are on birth control, and some of them are also on spironolactone. So every patient is different.
If a woman's listening to this and has, weight gain, acne, hair loss, just has the classic PCOS symptoms, what do you recommend?
Let's go over it. First of all, please go on OV. If you think you have PCOS, go on ovii.com. Take the questionnaire. It's free, and answer the questions. I cannot diagnose anyone online, but I can tell them if you have the likelihood of having PCOS, then you need to listen to this podcast and educate yourself.
Right. And so that's why we created the quiz, so that, we get this all the time. I need to go see Dr. A. And your response always is, I don't want you to come see me. I want you to be educated, and then you can arm yourself wherever you are. And that's really why we did the quiz. It's just the exact questions that you go through when someone walks in your office. So when I think about PCOS, I think, I see so many women that are overweight. But can you have PCOS and be underweight or average weight?
Yes. And to this day, doctors still think you need to be overweight to get the diagnosis of PCOS. But 25% of PCOS patients are actually, we call them lean PCOS. They're very thin, but they have all the other symptoms of PCOS. So you do not have to be overweight to get the diagnosis of PCOS. That's why weight gain is not part of the criteria for the diagnosis. For patients who are overweight, we talked about, you start with the GLP-1s. A lot of times you hear that so-and-so went on Mounjaro, lost 40 pounds, stopped it, and gained the weight back. Part of that is because you're not addressing the insulin resistance. So a lot of these patients, after 3 to 4 months, I add metformin to their regimen to be able to maintain their weight. Most of these symptoms improve with weight loss and metformin. However, sometimes you need to address them directly. For irregular periods, if it's not resolved, birth control pills are a good option. I want to make sure that patients understand that if they have painful periods also with PCOS, I usually don't give the combination birth control pills. I give a progesterone-only birth control pill. Some of them are very anti-androgenic, which can lower their testosterone and help their symptoms. Number 2, I would treat their acne. Again, if metformin fails, birth control fails, you can do spironolactone. I can fix acne by addressing the hormones inside and using some topical acne creams and moisturizers that most compounding pharmacies can make it for the patients. For hair loss, as long as the patients are on some form of birth control, I give them minoxidil. Minoxidil helps significantly. You can take it in 2 forms. You can take it orally, or you can do the topical, like Rogaine, let's say, on the scalp. That helps with the hair loss. And then with the facial hair and body hair, again, you have to fix the hormones from inside with everything we talked about. But laser hair removal, electrolysis is sometimes needed for these patients.
And so we get the question a lot, can you take OV with metformin? Can you take OV with the GLP-1?
Yes, absolutely. Okay. Whether you take metformin, you can be on the GLP-1s, you can be on OV, and you can be on metformin altogether.
Okay, so I just wanted to clear that because we get that question a lot.
Yeah.
Can you take it all? So, again, I just want to say the reason that OV is different in terms of the supplement is that it addresses the symptoms of PCOS and it works on the symptoms. I mean,
it's evidence-based, and
Yeah.
we have a lot of clinical studies on it for each ingredient that it does work. But it's multifactorial. Your lifestyle, your diet, your exercise, your genetics, all of it play a role. So, you just want to address every aspect of it. So overall, you can treat these patients.
So the day that we met and you started talking about PCOS and how you use the GLP-1s to treat your patients, and I had no idea what PCOS was. And then you said 15% of all women have it. You said spend a day in my office and it will break your heart. Yeah. A great example of this is the Mayan Lopez episode. Why don't we watch a clip from it?
And you were the first person to tell me that I had PCOS, and it just changed my whole life, especially insulin resistant. I had no idea what that meant or what that was.
I still remember when I told you, I don't know if you remember this. I remember which room you were sitting at when I told you this. Yeah. I remember one of the things you told me is I feel validated because I feel like she had been dismissed, and she walked in with every single symptom of polycystic ovarian syndrome. She wasn't missing a single symptom.
What can I say? I'm an overachiever.
So can you walk us through her treatment plan then?
So this is not something that suddenly happens. Patients with PCOS usually have family history of diabetes, insulin resistance, overweight family members. And a lot of times you don't know, like I'm insulin resistance, right? I gained 60 pounds with my pregnancy because I let go of my diet. If I let go of my diet, I'll sit here in 2 months, 50 pounds heavier. That's what happens with insulin resistance. So it's extremely common. But what happened with her, for me, when I see young patients with PCOS who are overweight, the number one thing to fix is their self-esteem. That's the first thing I aim, because self-confidence and self-esteem is a must in life for women. Without it, you can't function. You can't get to where you want in life. You can't find a good partner. You have to believe yourself. You have to like yourself. You have to love yourself. You have to feel good in your body. And has nothing to do with looks and beauty. It's just the way you feel about yourself.
You described
She was just sad. She was just broken. She was defeated. Defeated is the word I would use.
Like if I could have walked away from myself, I would. That was like where
she
was nothing.
Devastated when I diagnosed her. Devastated.
That was so brave of Mayan to share her story. Why are so many women dismissed? Why are 75% of the PCOS patients not diagnosed? The stories that we hear on this couch and this podcast break my heart, but you get them every day. So why do you think that is?
First of all, I want to say that even though the studies show 75% of women are not diagnosed, I think that number is a lot higher. So it's not only that these women are not getting diagnosed, even when they get diagnosed, they're not being treated correctly. So it's a double whammy. One, they're not getting diagnosed. Two, even when they get diagnosed, no one knows how to treat them.
Right.
If this was a male issue, it would have been solved years ago.
Yeah.
We would have honestly had a cure by now. But when it comes to us, there are so many reasons why women are not diagnosed. Number one, I would say women get dismissed, right? Every time we go to the doctor and we open our mouth, all we hear is, it's in your head, you're anxious, you're stressed. How often do you hear, oh, stress is causing this? Before you tell me it's caused by stress, why don't you do a workup? Why don't you listen to me? So number one, I think on the list is women get dismissed. Number two is there's not a single test you can do to diagnose PCOS. So the other reason is PCOS presents with different symptoms. Not every PCOS patient has the same symptom. For example, doctors to this day think you need to have irregular periods to have PCOS. False. They still think you need to have cysts on your ovaries to get the diagnosis of PCOS. False. They think if you're not overweight, then you don't have PCOS. false. So that's another reason. Because different patients have different symptoms, it's very confusing for doctors and clinicians to diagnose PCOS. There's not a single test. We talked about that. Teenage diagnosis could be very confusing because a lot of these symptoms of PCOS overlap with symptoms that regular, teenagers go through: the acne, the irregular periods, all of that.
So I think when I hear about PCOS and I want to know, when women come into your office, because you see so many of these women from all over the world, it seems like I'm hearing fertility and weight gain.
So actually, to this day, most people think PCOS is just a fertility issue. Now we know it's not, right? It affects your hormones. It can affect your metabolism. What does that mean? Like if you have insulin resistance, weight gain, androgen secretions, inflammation. So it's not just a fertility issue. To this day, people still treat it that way. And a lot of these patients don't get diagnosed until they can't have a baby. They end up in a fertility clinic. But even under the care of a fertility doctor, they still get dismissed. With good doctors, they do get diagnosed, but it's sometimes too late. So when we talk about PCOS, it's not just irregular periods and fertility. There's so many symptoms that affect these patients, and they go throughout life not getting diagnosed. For example, they gain weight and they try every single diet on this planet, different exercises, and they can't lose weight. They struggle with an eating disorder. They have acne. They go and take Accutane. They stop the Accutane, their acne comes back. They have facial hair, body hair. They're constantly lasering it, and it comes back. They have hair loss. I mean, sometimes you can walk on the street and just pick out these patients without even speaking with them. So that's how obvious some of these symptoms are. And really, when you don't address it, it eventually affects their self-esteem. It affects their well-being. And at its core, it's this PCOS syndrome that's like an umbrella that covers all these different symptoms.
So you sometimes tell me, every single patient that came in with endometriosis or PCOS, we cry together and they finally say, like, I'm heard,
or
oh my God.
Validated.
Yeah,
I feel validated.
So what happens?
So I feel like because these patients, we've had them on this podcast. One of them told us she's seen 17 gynecologists. How could that be? 17 gynecologists. Yeah. You don't see this in any other health condition, definitely not conditions that affect men. There's so much research on erectile dysfunction and Viagra. How do we not know what PCOS is? How is that possible? Yeah. We're not talking about some random diagnosis. We're talking about one of the top causes of infertility on this planet. Yeah. And 40% of these patients also have endometriosis, which is another top cause of infertility. So how is it that we still get dismissed? These patients already know they have PCOS because they're listening to podcasts, they're going on ChatGPT, but they end up at their physician's office and they're still getting dismissed. So why is it that someone needs to travel to come to my office, to wait in the waiting room, to pay my office visit just to get the diagnosis? It's complicated, but it's simple to diagnose. All you have to do is listen to the patient. You don't need a blood test. You don't need an ultrasound to diagnose these patients. When new patients with PCOS walk into my office, my medical assistants who have never gone to medical school diagnose these patients just by taking history. They come out and they tell me you have a new PCOS or you have a new endometriosis patient. Why is it that a medical assistant has an accuracy of probably 95% in diagnosing these conditions and our clinicians are not doing it? Let me give you an example. I had a patient, she's been under my care now for maybe 3 years. And she was first diagnosed with PCOS, endometriosis. When she came to me, she was about 100 pounds overweight. She had acne, she had hair loss, she had facial hair and body hair. She had no self-confidence. She was struggling with anxiety and depression. She had history of an eating disorder. So basically, she put a check mark in front of every single symptom of PCOS. Completely dismissed. She must have been in her late 20s. So I started treating all her symptoms. It took many years, obviously, but I recently saw her, and when I went in, she had set up her phone to videotape my reaction when I walked in. I walked in, she had her hair done. She had lost 100 pounds over the past 3 years, and her skin was glowing. And when I walked in and I hugged her, she looked at me. She said, I want to tell you something. And I said, what? She said, this is the first time in my life I know what it is to feel happy.
Oh my God.
Can you imagine?
And that happens to you all, I mean, every single day.
She was in her, I mean, how
Yeah.
could that be? How could someone in their late 20s, she never experienced happiness. And when she told me that, I'm like, that's what it's all about. You know, when you treat these patients and when you address their symptoms, this is what happens. Happiness was the result of all the treatments that we did for her. Confidence was the result of all these treatments. So it's extremely powerful. I can sit here and talk about these symptoms, but you have no idea at its core what it does to these patients. When you diagnose them correctly, you treat them correctly, and all it takes is, it starts by just listening to them. That's all you need.
And so these women that come to you, it literally changes their lives. And it's not something that happens overnight. I mean, you know, the GLP-1 start, that happens rather quickly, but it's not, you know, the metformin has to kick in, the OV, you know, kicks in. I mean, everything takes a minute. You know, you've always said, like, your body's not a light switch. So I think also, you know, for someone listening to this, be kind to yourself and be patient to yourself, because this is a marathon, not a sprint.
Right. On average, when you put patients on these GLP-1s, they lose about 46 pounds in 1 year. So someone who needs to lose 100 pounds, sometimes they need 2-3 years to get there. The metformin, the OV supplement, it usually takes 3 to 4 months to kick in. Birth control pills take 3 to 4 months to kick in. You know, my follow-up with patients are usually between 4 to 6 months, because you really need to give them time.
Right.
It's very important. You brought a very good point. Patience is very important, and dealing with symptoms at its core is just a must.
And, you know, we've had some women that are perimenopausal and menopausal get on OV too, because they start to get insulin resistance.
Yep.
There's no cure for PCOS. So once you get it, you have it forever. So how do you treat a perimenopausal woman or menopausal woman differently than, you know, a teenager or a woman that is dealing with fertility issues?
Good question.
Because guess what? We don't have to worry about the fertility issues anymore.
As we get older, as we get closer to menopause, we become more insulin resistant. What happens? We start gaining weight. So that's one of the main complaints of women going through menopause.
Like right around here.
Right. And a lot of times that's when you see primary care doctors or gynecologists prescribing these GLP-1s for weight loss, which is absolutely fine. The insulin resistant can be addressed with metformin for patients who are pre-diabetic. So all of those are an option if you're gaining weight as you're going through menopause. Hormone replacement, obviously we have so much good data now on hormone replacement. These patients do qualify for hormone replacement, especially testosterone. So what do we do throughout their life? We tell them your testosterone's high. Here's a medication to lower your testosterone. Here's a spironolactone to get rid of your acne and all these other symptoms. But as they go through perimenopause and menopause and their libido goes down, what do we give them? Testosterone cream, and it's absolutely fine to do. So I just want to make sure there's no confusion. If you've had PCOS, if you've been diagnosed PCOS, and now you're premenopausal or menopausal and your libido is down and you want to take testosterone, it is absolutely fine to do.
You know, you don't have to have PCOS to get on OV, but it helps, you know, the symptoms of menopause and perimenopause.
Yeah.
But a woman with PCOS, you know, she's suffering from the time she's a teenager.
Yeah.
Does it get better in menopause and after menopause?
So no, actually, as you get closer to menopause, we become more insulin resistant.
Right.
So some of the symptoms are better. The testosterone levels improve. Obviously, after menopause, we're not having periods, we're not having irregular cycles, but the insulin resistance becomes more significant. And that's why PCOS patients are at a higher risk for diabetes. They're at a higher risk of having coronary artery disease. So that's why it's a metabolic issue that needs to be addressed at a younger age. So you don't have to wait for PCOS patients to be 50, 60 years old to check their hemoglobin A1C, to check for insulin resistance, to check for coronary artery disease, and to address their cholesterol and triglyceride levels. So it's very important to address that aspect of it early on so you prepare them for menopause.
And so that's also a good point. So you've had PCOS your whole life, you're perimenopausal or menopause, so some of the testosterone symptoms go away. So then how do you treat somebody different, or do you treat somebody differently that's in menopause?
It's actually a very good point. PCOS, we always talk about androgens, right? High testosterone. However, when a PCOS patient is going through perimenopause and menopause and they have low libido, what do we give them? Testosterone, and that's absolutely fine to do at that point. So if they have hot flashes and they qualify for hormone replacement, great. They're at risk for coronary artery disease. We have some data on hormone replacement and cardiovascular protection. So they do qualify for hormones. They do qualify for testosterone, for energy, for muscle mass, for low libido, as they go through menopause. So there's a shift, though, in how you treat these patients.
And that is why when I met you, you explained this to me, and my mouth was open. And now, having seen all of these stories with these women that come on, I mean, the episode with Phebe, Greg Renfrew's daughter, I mean, that we were all sobbing. Why don't we play back a part of Phebe and Greg's episode? So I really kind of want to start, if it's okay with you, and hear your story, Phebe.
My PCOS story started probably 4 or 5 years ago now, at least experiencing symptoms of PCOS, honestly, for as long as I can remember now. I'm sort of that textbook case. Not only have I struggled with signs of PCOS, but also confusion my whole teenage life, really, with kind of like what was happening with my internal health, my body sort of not responding to me or not listening to me, whether that was through diets or exercise regimes. I had a really severe eating disorder about 4 years ago as a result of just so much frustration in my own skin. And it really started with my cystic acne that's been prevalent for maybe 6 or 7 years now. And so as I kind of entered into my later teenage years, after kind of already getting my period and starting to really go through puberty at not a young age, but definitely growing into myself at probably 13, 14, 15, I really started to notice signs that my body wasn't responding to the way in which I thought I was treating it with respect. And I've lived a very healthy, active lifestyle my whole life. And so these sort of frustrations and confusions that I didn't really know who to talk to about, and only then turn into really just like maladaptive behaviors. In the beginning of 2020, I was asked to leave school because I was really harming myself. With my eating disorder. So
this is
and
why
I'm actually in the first time in my life, like, okay, being emotionally vulnerable about these things and open and honest, because I found in what I'm so appreciative of what you guys are doing is the conversation is where it needs to start. As a person in my position, it's shocking to me that it took me this long, because I've privilege and access to the best doctors in the country right now. And it took me 5 years to understand what was happening with my own body, with something that you don't even need an ultrasound nor a blood test for. And that's PCOS specific. But I do think in that moment, I was so proud of myself that I had explained to my mom and my friends and my parents that there's something wrong with my body and that it's not responding. And that, I was just every single thing you talk about, probably on this episode, on other episodes, symptoms of PCOS, I have undergone, from severe eating disorder, weight gain, facial hair, crazy period pain, 12-day periods. Any symptom that you can think of. We talked about this in your office. I have literally checked the box, and I genuinely thought that for so long I was going crazy. I really did. I was like, no one listening to me. My mom has been amazing, and I'm also so lucky because I have a mother who cares about my health and cares about putting me and prioritizing my health. That's also not something that everybody has and every young girl has. So that's also something to recognize. So it was profound, and I'm so grateful. I'm internally indebted to you with that. And you've changed my life already by just hearing me and seeing me. But it was a really profound moment. And I'm just so grateful that there are more women who want to keep sticking up for one another.
If you look back, I'm sure you can think of women in your facility where you were going that probably had PCOS.
Yeah. Oh,
They're
1,000%.
They're
everywhere.
I mean, this is a young girl who has her whole life ahead of her, who, had to be in a medical facility for a year because, told she's not this, told she has an eating disorder.
Let's talk about that. That's so near and dear to my heart. Actually, my 12-year-old was asking me, Mom, I want to do some charitable work. She's 12 years old, and she obviously knows my passion is with PCOS and endo. And I told her, my dream for you would be to go knock on the doors of these eating disorder centers, because behind those doors, you will find the dismissed PCOS teenagers. They're all sitting there. But instead of someone saying, wait a minute, let me make sure you don't have any hormonal imbalance. Let me make sure this is not related to insulin resistance. Let me make sure you don't have PCOS. And I always say, especially with bulimic patients, please make sure these patients are not PCOS. The issue with PCOS is not just associated with a high BMI. We see it in lean PCOS patients. So I beg you, if you think you have an eating disorder, make sure you go to a PCOS specialist. Make sure to rule that out before you go down the path of all these other treatment options.
And I don't think that you have ever said that a single patient comes to you that thinks they have PCOS, you diagnose it, that doesn't literally sob almost on the floor.
Yeah.
And I think that was really what got my heart, where I just, these women that are, I try to imagine it. I try to imagine being all of a sudden, you have your period, you gain weight, you can't lose it, you're starving yourself, you're,
having acne, facial hair, body hair.
You can't get rid of it. All of a sudden, you're these young girls, and as a mom, it literally it breaks my heart wide open. And I think that's why when we met and you said, look, there's a simple way to figure out if you have PCOS. And there are things that you can do. You just have to have the knowledge. So again, that's why we created OV. The questions that you use for every single one of your patients is on our site for free. Go on. We're not diagnosing you, but it's, we can tell you the likelihood of having PCOS. And again, I cannot believe that one of the leading causes of infertility, and 1 in 10 women that have this, everyone's not talking about it. And they're starting to, I feel hope now. Having these incredible women, Florence Pugh talking about it, Sophia Ricci talking about it, all these amazing women that have a platform have helped us. But I just, when I think of being a mom of a child that is struggling in this way, and if you listen to the Greg Renfrew and Phebe episode, that's what happened.
It breaks your heart.
It breaks your heart.
Didn't you cry?
I cried the whole time. And so I think sometimes because we're moms and you're only as happy as your most unhappy child, to think that you don't, first of all, 75% of women don't know they have it. How?
I think that number is a lot higher. I swear it's a lot higher. For 20 years now, I've seen PCOS patients in my office. Majority of my new patient consults are PCOS and endometriosis patients. It's truly, truly heartbreaking. I can sit here and tell you how bad it is. We're not even touching the tip of the iceberg.
It's like we keep saying, it's not in your head, it's in your body. And there are things that you can do to treat your symptoms.
But close your eyes and literally close your eyes. Think of a 35-year-old woman who's struggled with her weight all her life. She has acne scars on her face. She has hair thinning. She has facial hair, body hair. She struggled with anxiety and depression. She struggled with an eating disorder. And now she cannot have a child. Put yourself in her shoes and tell me how that feels. And these are women, I see privileged women, who come to me. They have insurance, they have access, and they're still getting dismissed. If women who are privileged if these actresses are getting dismissed, do you think other women have a chance?
Well, that's why we're doing this. They do
It's
now.
really sad,
They do
though.
now because you're teaching them.
It's gotten better now because of the podcast, because of social media, because of ChatGPT. But years ago, I would diagnose someone with endometriosis. These are real stories. It happened all the time. And I would go over what the consequences of endometriosis is if, the patient didn't get treated. And these patients would leave my office. They would go for second, third, fourth opinions. And guess what those opinions were?
You don't have endometriosis.
You don't have endometriosis. So, and one of them came back 7 years later to me, infertile with chronic pelvic pain, stage 4 endometriosis.
So what do we do? So what do
educate,
we do?
empower yourself to be your own health advocate. There's no other way around it. That's the only thing. I mean, it's really frustrating.
And you don't have to have all of those symptoms.
Not at all. Different patients have different symptoms.
Guys, if all of this sounds like your experience or someone you care about, a friend, a sister, a coworker, we hope you're listening. This is your sign to speak up, ask more questions, and demand better care. PCOS is real, and it's time women left doctors' offices feeling heard, supported, and empowered, not ignored. Help us raise awareness and end the silence around PCOS. Remember, it's not in your head, it's in your body, and you can treat the symptoms of PCOS. You are not alone. We are here for you. The era of dismissing women's health concerns is over. That's why we're here, to rewrite the narrative. You deserve more than being told, just lose weight or go on birth control. You deserve real answers, real care, and the truth. Today, we're taking a stand and giving you the clarity you've been missing. We're giving you the information to be your own health advocate. Our mission is simple: to shine a spotlight on PCOS, to share our stories, and to educate. It's time we advocate for women everywhere. We are here to break the silence around PCOS, to tell every single woman who has suffered in silence for far too long. We see you, we hear you, and we are here to help you. There is power in being seen, being heard, and being understood. We hope you got that from today's episode. For more information on PCOS, visit shemdpodcast.com and ovii.com. Together, we're gonna change the conversation. Thanks so much for joining us today on SheMD.
If you want to own your own health, a good place to start is by following us on social media at SheMD Podcast and by subscribing to our show on YouTube or wherever you get your podcasts.
For takeaways from today's episode, visit our website, shemdpodcast.com. We'll see you next time on SheMD. This podcast is for educational and entertainment purposes only. It is not intended as a substitute for a physician's medical advice. You should regularly consult your medical provider in matters relating to your own health. Even though we share our honest beliefs on SheMD, some of the products and services we discuss may involve sponsorships or paid advertising.